Next, we will hear from Dr. William Beecroft, Behavioral Health Medical Director at Blue Cross Blue Shield of Michigan. He has been instrumental in the development of innovative programming in behavioral health, including collaborative care, crisis programming, provider-delivered care management, and first episode psychosis programming. We're grateful to have Dr. Beecroft here today to share Blue Cross and Blue Shield of Michigan's efforts to support mental health and crisis services. Dr. Beecroft?
It's been an honor to be on this distinguished faculty panel today. It's an honor for your time to listen to our story of being able to help individuals in our community be able to access care. It's been an honor in my career to be able to take care of a lot of people with behavioral health conditions over 38 years in practice. And then here at Blue Cross Blue Shield of Michigan, it's been an honor to really help develop, along with the team and along with the company, these services to be able to improve access and be able to help people. And all those things that they said I did, I didn't create those all myself. It's been a whole team that's been doing this, and we only took the literature and its evidence-based as an evidence to go forward. But with crisis services, we'll dive right in here. It's the right care, the right time, the right place. SAMHSA, I think, has put it together very, very well in their roadmap to crisis services. Next slide, please. And what we're really looking at doing is trying to be able to do things that the public system has been doing for 20 years or more very, very well. You can move on to the next slide, the executive summary slide. In many respects, they have gotten it right to be able to get urgent and crisis-based interventions done quickly. Emergency rooms are very good to be able to take care of people that need services, but for behavioral health services, they can be life-saving, but also they can be very difficult to work within. I did an awful lot of that in 38 years. And being able to have confidentiality, being able to have a quiet space, being able to have a safe space, because in anyone that's gone into an emergency room, there's all kinds of wires and things you can hang yourself on and hurt yourself by cutting. There's all kinds of things that can get you in crisis. So being able to look at crisis services, I think, is really something that we can develop an alternative path to getting those services that are really required for those individuals met. Psychiatric urgent care is taking on kind of a life of its own, but this is for, just like urgent care for medical services, a place that people can go, be able to get assessed fairly quickly. If they need higher levels of care, that can be helped. But usually it's things like being able to get, a prescription refilled, or being able to find out if they have something that needs to have higher level of care, can they get an outpatient therapy appointment and kind of work in that direction. Where we've really picked up the task is developing a system of payment for mobile crisis services and crisis stabilization. You can go on to the next slide. We also have crisis residential already paid for. The next slide shows the mobile crisis concept, and being able to have a mobile team. You can move on to the next slide. Maybe hanging up. There we go. A mobile type crisis team is a master's level provider, at least, with a peer support that can go out to a person's home. They can go to a primary care doctor's office. If the primary care doctor, we need to go back one, I'm sorry. Back on the mobile crisis slide. They can go to a primary care doctor's office who's done the screen of a PHQ-9 and ask the number 9 question, are you suicidal? And they could be able to come into that office and assess that individual, be able to look at what is the diagnosis that we're dealing with, what would be a nascent treatment plan to be able to put together, be able to coordinate that with the individual and or their families. We have this also available for children. And to be able to put together a plan that they might be able to get a psychiatric appointment quickly within maybe later that afternoon or the next morning, get them involved in a partial hospital program, or take them to a crisis stabilization unit, which we'll talk about in a minute. They could also go into an emergency room to be able to help provide those services that many emergency rooms don't have especially don't have quickly. And in our plan, the providers that we have can either reach out by telemedicine or they can reach out in person within minutes to hours, not hours to days, like sometimes happens in emergency rooms. I'm not beating up on emergency rooms. They're extremely important in our society. But for people with behavioral health conditions, this may offer a substantial alternative level of care that can provide more focused, more directed care towards their needs. Next slide to the crisis stabilization unit. A crisis stabilization unit is actually a physical location. And this is an example of one of our providers' lobby area, kind of the setting that you'd be walking into as a citizen coming in from a community. You can also call them. They can do this by telemedicine to a certain extent. But the actual physical examinations really need to happen in a facility. And we're also looking at being able to house people overnight for the observation part of it. Crisis stabilization units are akin to a med-surg observation unit, which has been around for about 25 years. This is a place where you'd come in, you'd be triaged into a meeting with a mental health professional. At that point, they could make a thorough diagnostic evaluation, an assessment, work out a treatment plan with you of what you agree to be participating in and what your needs might be able to get a psychiatric evaluation if needed. And at that psychiatric evaluation, treatment could be initiated. Also, if you didn't need the psychiatric evaluation for medications or additional psychotherapies, the mental health professional that saw you could initiate treatment of a psychotherapy of whatever need you have, a family therapy appointment. But you're also there working with peers, and if you need additional testing, say medical testing, laboratory exam, imaging, anything like that can be done in this type of a facility or coordinated with this type of facility. So the treatment would be initiated. You could be observed for a period of time. You could overnight. And just like the med-surg observation units, the length of stay we're looking at is no more than 48 hours. That we really need to triage you into the next level of care, and that care needs to be coordinated by a warm handoff. It could be a crisis residential program where you're going to be staying a bit longer in a 24-hour-a-day supervised setting. Could be into a partial hospital where you actually are going home at night. Could be in an IOP where you may be going to work and come into this 3 or 4 times a week, or outpatient work. You still could go to a hospital. SAMHSA says that about 40 to 45% of people are still going to need a psychiatric hospitalization, even if they go to a crisis stab unit. But the idea here is that the other 55 to 60% don't need that level of care and can get care that they need in a less stigmatizing, a more comfortable, a more confidential space. Next slide, please. There's a couple slides here that we'll probably skip through pretty quickly because we've already gone over the distribution of services. This one goes over some of the things that you've already seen. So we can move on to the next slide. I think in an effort to preserve time, I will skip over some of these pretty quickly, but this one is really important because now I'm moving into talking about another alternative way of being able to improve access. We know that about 80%, arguable between 75 and 80%, 85% of primary care doctors of prescriptions for antidepressant medications are made by primary care doctors. We know that the mental health and behavioral health workforce is not enough, not adequate for our population. So the two teams really need to ally together. And that's where collaborative care can be a really significant value going forward. In 2014, Milliman did this report and looked at 14% of the patients with insurance consumed 30% of the total medical spend for their care. So this is the business case of looking at not so how expensive behavioral health is, but how important it is to treat the entire person, not just their behavioral health needs or their medical needs, but to treat them all. been mentioned previously that people with schizophrenia die anywhere from 25 to 28 years earlier than an age-matched population without schizophrenia. And it's really important to take care of them, as well as people with depression, all the other mental illnesses that can occur, and substance use disorder. We also know that the medical costs for treating people with chronic medical illness as well as mental health illnesses are 2 to 3 times higher than those for treating people with conditions that are just one or the other. And also the majority of projected savings is from the integrated care are associated with facility, hospital, and emergency department utilization. Integrated care is an important term because there's multiple forms of integrated care. We have chosen to move towards the collaborative care model. That doesn't mean that the other models are not effective and helpful, but the collaborative care has the most data to support it and evidence-based, and that's where we have focused our energies. Next slide, please. Collaborative care has a little different team kind of orientation, and it's population focused because we screen everybody in the primary care practices and identify people with primarily anxiety and depression, but we're also looking at pediatrics populations, substance use disorder populations, populations of people with severe mental illness. And it can be also, we're looking at developing a high-risk pregnancy perinatal program to be able to use this. It's measurement guided, PHQ-9s, GAD-7s, whatever the tool, whatever the population you're really screening for is what tool you can use. And it has substantial evidence base. There's over 90 evidence-based trials that show collaborative care to be very effective. Next slide, please. The model is a little different than a regular practice in medicine. In many respects, the medical field, the primary care field, has always been the primary provider, being kind of the captain of the ship. And over time, we have developed other things. We've developed other practice strategies using team medicine. The family-centered medical home was one of the first ones, and then provider-delivered care management came along about 12, 14 years ago. And now collaborative care is another descendant of those team medicine components. But what we add is the psychiatric consultant and the behavioral health care manager that coordinate what's going on with each case that has been screened into this program. The behavioral health case manager is the primary liaison along with the primary care doctor to the patient. The psychiatric consultant never sees the patient directly in this model. They can do a consultation, but that is a rarity. Mostly it is that psychiatric consultant is reviewing the cases, being able to advise the primary care provider as to what's the next step in this person's care, be it a different type of psychotherapy, getting them into psychotherapy, being able to look at which medications might be appropriate. If the medications are ineffective or they're having side effects, how to be able to change, how to be able to add adjuvant medications to this. And when enough is enough in this setting and we really need a second tier or tertiary care intervention for that particular individual. Another big piece of this is being able to have people's data really checked through this systematic case review tool to keep tabs on the progress, to keep tabs on the labs that are going on, the interactions with their therapists, these sorts of things. Next slide, please. So a couple testimonials here, and then I'll jump on to another couple slides, and then we'll be able to have some questions. But a patient testimonial, and this is a real patient. This isn't just an actor telling you all these things. This was a family member who was enrolled in collaborative care. She enrolled for about 2.5 months, uses the tools every day, learned during her calls with the behavioral health case manager what she needed to know about the issues that she was dealing with, and looks forward to her follow-up calls. The other one is a provider testimonial. And the biggest thing from this is that the collaborative care model made a huge difference in that particular provider's ability to manage their patients' mental health in the long term. Case manager has been able to spend more time with me, has been able to provide vital information, and in helping to manage the patient's complex social and mental health outcomes. In this model, they can also deal with the social determinants of health, being able to look at the logistics of getting people where they need to be, coordinating with the other people that are touching them in the care modeling system, and families, being able to coordinate with family members. I go to a lot of regional medical directors meetings, and what I hear back is that from the primary care doctors especially, is that, you know, we're 75, 85% of us are burned out. You know, many times colleagues of mine from working in the hospital say, I really don't want to be a doctor anymore. I want to go be a carpenter. I want to do something else. After a year in this program, I get the feedback, hey, I love my job. I love being a doctor. My patients get better. I want to go to work every day again. So much different. And we can't afford as a society to let any doctor just leave medicine because they're burned out. We have to take care of them to be able to move forward. And I say doctors in a very generic term, any healthcare provider at any level of care. Next slide, please. So in Michigan, we've really done a very aggressive program to be able to pull together and train providers. We have been able to train up 180 practices in the last 2.5 years. We had put away some practice transformation funds that was available for us to be able to do this. And after making the case to our senior administration, and they very heartily grabbed this and said, this is a great model to move forward with, and has been very helpful in backing this program. 84 have been added in 2021. We developed a pediatric module for our training programs, and we've partnered with a large Midwestern university and also a clinical innovations program on the west side of the state. So we have a distribution of using the same curriculum that we all developed together, but an ability to train people in different parts of the state to be able to do this. The pediatrics practices asked for us to develop this module. And so we put this together and we've trained up 20. They're really working quite well. These are practices, and practices aren't just one doc or one nurse practitioner or one clinical nurse specialist or PA. They're a bunch. So we have 600 practitioners that we've actually trained and 800 practices, 800 should be practitioners, not practices, receiving the value-based reimbursement that we offered to get people incented to do this kind of work. We're also launching a co-care designation program to be able to then have our members and case managers be able to find these programs much more quickly than us knowing where they are. Next slide, please. I think that brings us to probably questions. Oh, our pediatrics adolescent model. This is the adolescent model. It really does look at the difference with adolescents and kids. We've driven this down to about a 10-year-old is probably the earliest age group we want to try to manage in a primary care setting with these kinds of needs. But the additional components of that practice is looking at community-based services, therapy, therapists, medical, being able to coordinate with health coaches and community health workers, peer supports, to be able to really help all that system work together. And consequently, it takes more time for the behavioral health care manager to be able to manage these cases, and their caseload can't be quite as high. But the additional members, as you see on the right there, is the parents, schools, the therapists, other community resources can be extremely helpful. And we can move to the last slide. So the key takeaways here is that crisis services can really offer specialized, specific care, being able to decrease stigma because you're going to not necessarily an ER in a very unconfidential place, but being able to have a confidential place that's not necessarily associated directly with a hospital, although they can be. They can be on the hospital campus. It's a more comfortable setting. It's safer in the greater scheme of things, and can be able to utilize the acute care hospital setting for people that are having other severe life-threatening needs, such as a heart attack, a stroke. It's not to say people with behavioral health conditions don't have those also. They do, and they need to be in that ER also. But for people that don't have those immediate needs, the crisis services really can be an additional adjunct and an alternative path. And collaborative care really increases access. In my practice, I panelized at about 600 to 800 patients. That's as many patients as I could take care of effectively. In this practice, I've talked with other people that have been doing this and other big centers. We're thinking that about a psychiatrist can be able to have psychiatric influence on the care of roughly 2,500 patients. So that multiplier of being able to work as a team with primary care and psychiatry together, being able to really work on taking care of individuals with a trusted provider that the individuals have. They have a trust of their primary care doctor, less stigmatizing. They don't know, nobody from the outside knows if you're going to get treated for a cold or for your depression. So that really prevents that issue of stigma in general. So with that, I would open it up to questions. And again, thank you for your time for listening today.
Thank you so much, Dr. Beecroft.